So, the first talk, I was going to do an overview of MS, what causes it, et cetera, what makes it better, what makes it worse, the treatments that are available, the old treatments, the new treatments. And the second part of that talk was to really focus on progressive MS. And guess what? We had a lot of questions. We didn't get to that. And I think that's just fine. But I thought I would start today's talk finishing up the first talk. Now, you should have a handout from the first talk. And I think that the title of the first talk was something. MS Disease Therapy Update, including PPMS. Hopefully you have that. If you don't have it, let me know. We'll get you a copy of it. But yes, ma'am. Pardon? I gave copies out the first talk. Everybody should have a copy. Let me see. Yeah, there are two handouts. One is the one I gave you before, and I'm just finishing that talk. And the other is complementary and alternative medicine, which I'm going to talk about when I get through. But my feeling is the most valuable part, there are two valuable parts of what I'm doing here. I'm giving you sort of an overview of this, but I'm giving you a handout. So you've actually got, so I'm going to talk about a lot of different medications today, and I talked about them the other day, and you're not going to remember those. You can't even pronounce them. I can't pronounce them. And many of them are just numbers and letters and stuff like that. But you've got them here. You can take them home and Google them. You can get that information for yourself. So that's why I like to give you handouts. But if anybody missed the first talk and doesn't have a handout, let Gay know. Gay can help get those to you. And I also wanted to talk about this book. We gave out a few copies of this book. This is a book that I wrote with a nurse, et cetera. It's called Primary Progressive Multiple Sclerosis. We did this a couple years ago. And if you didn't get a copy the other day and you want a copy, you can get them on Amazon.com. The National MS Society may have copies as well. And I think it's like 10 or 15 bucks. I don't know how much it is. It's not terribly expensive. This is not a commercial. I don't make any money from this book. This was done because we had nothing. We had no books on primary progressive MS. There was no place for primary progressive patients to turn. So we put together our knowledge of a bunch of healthcare professionals and put out this booklet. So let's get right into progressive multiple sclerosis. What I'm going to try to cover today, I need this, don't I? What I'm going to try to cover today, can everybody hear me okay? Is first of all, what do you mean by primary progressive MS? How does it differ from secondary progressive MS? What's the treatment approach to primary progressive? So many patients come up to me who've had primary progressive disease for 15 or 20 years and say there is no treatment approach. Nobody does anything for me. So I'm going to talk about that. And then I'm going to try to define a good day versus a bad day in the life of people with progressive MS. And these are quotes from patients of mine over the years that I've just put down saying, you know, what kind of a day you're having? I'm having a good day. Well, what do you mean by that? So I'm going to go through some of those quotes. And it's really different when you have progressive disease, at least from my experience, my patients with progressive disease versus my patients with relapsing disease. The relapsing patients are saying, I feel pretty good. I haven't had an attack in 2 weeks. Or I really feel badly. I'm just getting over an attack. The response with people with progressive MS is very different than that. And it's manageable. So many of the issues that you can take a bad day and turn it into a good day are manageable. And I thought I would just go through those with you. And then I thought I would maybe get your feedback as well. Is what do people with MS, with progressive MS, say they want and need? Well, everybody says I want a cure for the disease, but when we get past that, I thought I'd share with you some of the things that patients have told me over the years. I ran the Rocky Mountain MS Center at the University of Colorado for 20 years. It was one of the first MS centers in the world. It was the largest MS center in the world for the 20 years I ran it. And so we did a lot of work listening to patients and trying to figure out what's going on. We had 65 employees who did nothing but MS. And many of those were health educators, psychologists, rehabilitation people. Yeah, we had a few neurologists spread around too, but the major focus was helping people live better lives. And so I'm going to give you some of my experience from those days. And then I'm going to start talking about treatments for MS. This book, which is pretty recent, has essentially nothing about what I'm going to talk about. This is like 2 or 3 years old. That's how much has happened in the last 2 or 3 years. And my ultimate goal today is to have people with progressive disease walk out saying, thank God they're thinking about me. Thank God somebody's doing something to help me. And I'm going to have treatments for my disease like people with relapsing MS have for their disease, hopefully in the very near future. And then I'm going to end up by talking about quality of life. And you've heard a lot about quality of life and things to help quality of life. And then we'll go on to complementary alternative medicine. You know this. Progressive MS, slowly progressive, independent of relapses. You don't have to have a relapse to get worse. Just, over a period of time, I'm just a little bit worse than I was before, and it keeps getting worse and worse and worse. And there's really no meaningful recovery with people with primary progressive disease. They have good days and bad days. They have good weeks and bad weeks. They have good months and bad months. But if you look at it over a period of a few years, they're always worse. Although some people may stabilize for those period of time, nobody gets better, essentially. I mean, you'll hear people that I got up and ran the 100-yard dash or something like that, but those aren't my patients, I can tell you that. And we have no treatment for purely progressive MS. We have treatments for people who have relapses still and progression, that's secondary progressive MS. But for the people with primary progressive, we've tried so many different things. But we've learned from those clinical trials that didn't work, didn't get approval. And we're taking some of that knowledge to the next generation of treatments for this. All right. What's the difference between primary and secondary progressive MS? Well, secondary progressive starts with relapses. They'll have relapses maybe for 5 years or 10 years or a few years, and then they'll start getting worse between the attacks. Now, relapsing remitting MS means you have an attack, you remit, and you're stable until the next attack. If you start getting worse between attacks, you're then considered secondary progressive MS. Does everybody understand that the secondary progressive MS starts with relapses? And primary progressive relapse, primary progressive MS, you don't have relapses. You're slowly getting worse. You may have good days and bad days, but over a period of 6 months to a year, you just slowly get worse. And it may not be like this. It may go like this, fluctuate a little bit, but the end result is it's down there. And primary progressive MS affects 10 to 15% of MS patients. So it's not a small number of MS patients. As opposed to relapsing MS, where it's much more common in women, 3 times as common in women as men. And primary progressive disease, the risk is about equal. We see equal numbers of men and women. We don't know what that means, but it makes us think there's something different about primary progressive than relapsing remitting MS. 66% are married, 18% are divorced, 10% were never married, and 5% were widowed. What that tells me is that in this slowly progressive disease, relationships are easier to maintain. 66% married is pretty high in the dates where 50% of people get divorced. More people are married. And I think it's also because they're a little bit older. Progressive MS patients are a little bit older. They're more stable emotionally. And so it doesn't mean that your family life is destroyed with this. And 2/3 of primary progressive patients are actually over the age of 50. And we talk about relapse remitting MS as a 20 to 35-year-old disease, usually.
I was 16.
What?
I was 16 when I was diagnosed.
You were 16 when you were diagnosed?
Well, they suspected it then, but I was firmly diagnosed at 22.
With primary progressive? Okay. Again, there's different people on the different spectrum. I remember 1 week, a couple of years ago, I had 2 people aged 77 years old come down with a relapse remitting MS. I say, you can't have that. You can't have that. But they did. So therefore, don't ever say never. But I'm talking about in general. People are over the age of 40 when it starts. It usually starts with lower extremity stiffness, maybe some pain, some bladder trouble, some bowel trouble, sexual dysfunction, and just slowly gets worse, and it's usually a disease in the 40s. So, and we don't know. When we see people who have primary progressive at age 16, we sort of scratch our heads and we say, what are we missing here? But it can happen at 16, it can happen at 40, it can happen at 70. Let's talk about what do we mean by disability. Most people talk about disability as I can't walk, so I must be getting disabled, and that's true. But it's more than that. Cognition. It can be an important part, not everybody, but of some people. They have progressive cognitive problems. Vocational issues. They may not be able to do the job they did. Even though they may still be able to walk, they can't do the job. And I think that one of the most important points I'd like to make is the quality of life can deteriorate with people with progressive disease. And that's really our job as healthcare professionals and people who take care of MS, is to keep that quality of life high. I'll give you a quick story. I don't want to take up too much time with stories, but I think this will be illustrative. I was at Johns Hopkins training in multiple sclerosis, and I went to the University of Colorado for two reasons. One, there's a lot of MS in Colorado, and second, it's where you can ski, and I like to ski, and I thought I'd combine those two loves of my life, MS and skiing. And I started seeing, there were no, this was 1975, no treatments for MS at all. And I started seeing all these people I felt so badly for. You know, I would go home and worry about them at night because we had no treatments. And then one day I saw a man, a Hispanic man in a wheelchair, about 55 years old. He had primary progressive disease. He's the greatest guy, such a great guy, but just incapacitated in this wheelchair. And I remember going home that night and feeling so badly for this guy. He has everything to live for. You know, he's got a great attitude. And why is he in a wheelchair? Why can't we do something about it? Because we had no treatments. I saw him that weekend because I would go to picnics for MS patients on the weekend and answer questions and do stuff like this. And he's in the wheelchair. He's got one grandson on each knee. He's watching a third grandson play soccer out in front. And they're cheering and happy. And I'm thinking, wow. On my best days, I probably am not that happy. He's in a wheelchair. He's with his family. He's doing something he loves to do. So the point I'm making is quality of life is a feeling. It's a health state. It's not whether you're weak or not. And so just keep thinking about that. And so what creates good quality of life? I think, first of all, you have to be as healthy as you can, whatever that is. You have to take care of yourself. You have to diet. You have to exercise, that sort of stuff. And then the next thing is feeling like the next higher up is feeling productive. Well, so I can't be productive. I don't work. You people in this room who don't work, very productive in their church, in their volunteer organizations, in their letter writing campaign, in their Googling and all that sort of stuff. Very productive, can make an incredible contribution to life. The next highest up level is relationships. People who are very disabled, who have really good relationships and have a loving, caring, sharing relationship life, both friends and family. If you ask them what their quality of life is, they'll say, it's pretty good. You know, I'm going to a bridge party, or I'm going to do this with my friends, and my grandchildren are coming over this week. They say, it's pretty good. You know, you look at them and say, wow, they're in a wheelchair. How can that be any good? But it's because they have good relationships. The highest quality of life, and again, this is a diversion because I wasn't going to lecture on this, is I think people who feel creative, who can do things that hit those creative juices. It doesn't matter what your disability, physical disability is. If you feel like you can do a project in your church or your community. I have a lot of my patients who work for Chamber of Commerce, and they're all doing all sorts of little projects, being creative for this. They love going to work every day, and they don't get paid for it. These are volunteer positions. So, okay, I'm going to do this really quickly because I want to get to some other topics. But my primary progressive patients, these are some of the things they tell me when they're saying they have a good day. I feel energized. I don't have any pain. I'm thinking clearly. I'm not feeling stressed. I get up, get breakfast, go to lunch, have a good afternoon. I go bowling with a local support group in my wheelchair. I walk without pain. I haven't had constipation in 3 or 4 days. It's a good day. One person said, I'm having a good day because the sun rose. Any day the sun comes up is a good day for me. It depends on just how you respond to things. It's not what happens, it's how you, as Jimmy Hugo used to say, the skier with multiple sclerosis, it's not the cards you're dealt, it's the way you play your cards, the cards you're dealt. And I think that's really good for everybody. Play those cards differently. I attended a basketball game with my kids, and my children are helping me do stuff. That's a good day for a person with that. And anyway, I'll go to, now these are bad days. Now, in a relapsing patient, bad days, I have had an attack in the last week. You know, that's what they really focus on, that attack, that attack, that attack. In my primary progressive patients, they say, it's a bad day because I can't live on my own. I have catheter issues. My chief wheelchair just doesn't fit right. I'm so tired. I'm so stressed. I feel depressed. It's hard for me to dress. The heat's killing me. I feel stiff. I fell today. I have nothing to look forward to. I have no human contact most of the days. And it's a bad day for when I find myself complaining all the time. It's a bad day when I stay at home while my kids are outside playing. And anyway, those sorts of things. So if I try to summarize the good days versus the bad days, because that's what we as healthcare professionals I think should do. Saying, how can we turn bad days into good days? We're not talking about medications here. We're talking about quality of life. I think the bladder control and the catheter issues are major issues for people, causing them to have bad days. Isolation, social isolation is a huge issue. Cold weather is usually a big issue. A good day is when they're doing activities, they're thinking clearly, and they're working with their families, and they're doing things for themselves. Notice I didn't talk about medications. I didn't talk about the neurologic problems, the physical disabilities. I talked about the human disabilities. So then I asked my patients, what can I do for you? What would you like help with? What do they want? They want more research, and they want treatments. They feel they're the forgotten disease in multiple sclerosis. They want better communications with their healthcare professionals. And there are ways to do that. Healthcare professionals are not impenetrable. And that's something to work on. They want more information. There's almost no information about primary progressive disease out there, which is why we wrote that book. They want counseling, especially early when they're just starting to have this progressive. They have real trouble adapting to this and adjusting. They want counseling. They want to learn coping and adapting skills. They want exercise programs because they know exercise will create a better quality of life for themselves. They want somebody that they can call. They want a care coordinator, whether you call it a navigator, whatever you call it, somebody who can get them through the system. It is so hard to get through the insurance system. Sometimes it's so hard to get to a doctor's office. If they had one person, they can say, I've got this problem at work, I've got this problem at home, I got this, and they can say, well, these are some of the solutions. And those are the things that we're working on. Vocational guidance. If I can't do what I'm doing now, what can I do later? And you'll be surprised how poor vocational guidance is for people with progressive disease. And one of the things they almost always say, I want help for my care partner. I know what a stress this is. Now, you're going to have a talk later today by Laura about care partners, and I'm not going to spend any more time talking about that, but I can tell you it's near and dear to my heart. We really need to respect and help the care partners more. And they want more symptom management, so we'll talk about that as well. They want the best health care, and they want a team. They don't want an individual doctor. They want a psychologist and a physical therapist. They want these people working together. Everybody knows them. And they want the best mental health. They want the best mental health they can get, whether it's mood, thinking, memory, whatever it is. They want to figure out ways to get support from their friends and family. They want help with insurance and financial planning issues. People tell me, I want to feel safer. I want to be safe. And that means a lot of different things to a lot of people. But that's a key question for me as a healthcare professional. When I hear that, I need to address that. and saying, oh, I'm so sorry, tough luck, is not a way to address that. They want programs such as aquatics, yoga, Tai Chi, Pilates, biofeedback. They want spirituality, self-hypnosis, guided imagery, stress management. Many of the things you're going to see this week, some of the things you've already seen, and some of the things that you'll see later. To put those, incorporate those into your lifestyle is very important. And they want rehabilitation. Some doctors say, well, you can't rehabilitate MS patients. You know, rehabilitation doesn't really help that. That's absolutely false. If somebody tells you that, ask somebody else for a second opinion. They want energy conservation. They want fatigue management. They want help with their walking. They want help with their stiffness. They want help with their balance. They would need sometimes aids. Some people say, well, I don't want a cane, no. I don't want canes, no. I don't want people to see me with a cane, so I don't go to the grocery store. Or I don't go shopping because I'm in a wheelchair. I don't want people to see me in a wheelchair. Well, that's something you have to think about because it isn't, the issue in life is not getting from point A to point B. The issue is getting to point B and enjoying it. And if you have an aid that can get you from point A to point B and you can enjoy what you're doing at point B, as opposed to you stay home at point A and do nothing, I think that if we look at the pluses and minuses, it's better to be out doing what you want to do. And if you can have a cane or a walker or a wheelchair to help you get there, and you can enjoy your life. But if you miss dinner with your family at a restaurant because you don't want to go out in your wheelchair, that's the problem that's a problem with quality of life. Speech problems. Swallowing problems. I just talked to a lady before we started about swallowing problems and how difficult that can be for some people. And bowel, bladder, and sexual problems. Well, we don't talk about those very much. It's amazing the number of doctors who don't ask their patients about bowel, bladder, and sexual problems. But you have to address those because that increases the quality of life. People want to explore recreational opportunities. Duh. What a great recreational opportunity this is. And we help build ramps out to fishing ponds, and we've done all sorts of things to help people get outdoors. I started a handicap ski program in Colorado when I was there in about 1978, when you were not allowed to exercise MS patients because it made them worse. That's what the dogma was. You can put people in wheelchairs if you put them to exercise because the exercise will tear apart their bodies. We started a handicap ski program, and I can tell you today it's very successful. And that's what, 35 years later. They're still doing handicap skiing for some people. And we're talking about people who are in wheelchairs. Jimmy Huga, the skier, I used to ski with him, and he sat down on a sit ski. He could ski sitting down because he had trouble with his legs. There's ways to get around this. People want legal assistance, financial assistance, and they want life coaching. And they also want help with transportation. So what's the most important things that I've heard from patients? They want to be normal. Well, I don't know what that is. So I'd ask them, what does that mean? And they'd say, I want to be as independent as I possibly can, given my level of function. And if I'm functioning up to my maximum capacity, that's normal for me, and that's what I want. I want to maintain my dignity. I want to be able to socialize. I want to figure out ways to help my thinking so it's better. Whether it's making lists, et cetera, I want to say, how can I help myself if I'm having trouble with my thinking? I want to maintain a good quality of life. I really want to stay connected with my friends and family and my healthcare professionals. I want to be productive. I want to contribute. How can I contribute? Well, I can tell you, everybody in this room can find a way to contribute. It's just a matter of what that niche is for you. And they want to have a feeling of psychosocial well-being. They don't want to be isolated. They want more information. Because people, you don't give talks on primary progressive disease because we have no treatment, so therefore why talk about that? I think it makes doctors uncomfortable not to talk about something they don't have treatments for. It's so much easier to talk about the 10 FDA-approved treatments for multiple sclerosis. It's harder to talk about, well, we don't have any treatments for you, so maybe I don't want to talk about that. Well, I do want to talk about it, and I want you to recognize that we're doing something about that. In the meantime, there are so many things you can do for yourself to improve the quality of life. They want to participate in clinical trials. They say, give me a chance. I'll go on a clinical trial. I have nothing else to offer. They want informational alternative treatments. I'm going to talk about those in the next talk, so I'm not going to talk about those right now. But what happens is that I call MS the cure of the month disease. And when that comes out, they want to know what's going on. So what's a successful treatment? Well, I think if a patient tells me this, I think we're doing okay. I know I have primary progressive MS, but thinking about it does not occupy a large part of my energy. I have a reasonable understanding of my MS in my life, as well as the many other important aspects of my life. And I'm a person with primary progressive MS, but I'm not a victim of the disease. I think we're doing better when people can come to that realization. And maybe that would be a goal that you could set for yourself. So quality of life for PPMS patients. They want to feel understood. They want to be productive, creative, and valued. And they want to have this high quality of life. So the take-home message is happiness is a state of mind, not a state of health. And if you think about that, it is a state of mind. So with that, I'm now going to go about treatments. And one of my points is you're going to leave here today saying, wow, they are really doing a lot for people with progressive disease. And you have a handout for this. You can take it home and look this up. I'm not going to go into these in detail. I'm doing this to overwhelm you about how much research is being done on people with primary progressive MS. And you can look up the details later. Rituximab. It has, I think, has significant potential. It's not going to be used anymore, but the first treatment trial, rituximab, gave us some hints of how it may be helpful in the future. But now we have a new medication that's more humanized. It's a monoclonal antibody. It's a more humanized treatment, and it will take over from rituximab. There are some drugs like Gilenya. Do you know Gilenya? We talked about Gilenya the last time. Well, there are some copycats that are like them that may actually be more active. They may have less side effects. We don't know. But what we do know, Gilenya is being tested in primary progressive disease right now. We'll have the results in a year or so. And these copycat drugs, which are different, but they have the same philosophy, may actually work as well, if not better. So we've got these drugs coming down the road. There's something called a T-cell vaccination, where you take the myelin, the T cells that are active against myelin, the ones that are damaging the myelins, you take them out of the body. You inactivate them, and you put them back in. And there's some encouraging results that this may help stop demyelination. And it's being tested right now. It's a new way to look at it. The statins. Well, the statins have been mainly used in trials with relapsing forms of MS and relapsing remitting forms is what we think about it. But the last study that was done, it showed that it decreased brain atrophy and disability. Whoa, now we're talking about progression. If we're talking about decreasing disability and we're decreasing brain atrophy, we're talking about the potential for progressive disease. Tisabri, and we talked about Tisabri, you know about Tisabri. It's also being used in a trial in secondary progressive disease. And diclizumab, which is another monoclonal antibody, has some very good results also with that. So those are the trials in secondary progressive and some in primary progressive. In primary progressive, the big trial right now is Gilenya, should know in 2015. Ocrelizumab is the rituximab replacement. It's now being tested, and I can tell you, it's incredible. What it does, it apparently resets the body's immune system. Because you don't have to take it very often. Maybe once a year, maybe once every 2 years. What happens? You knock out the B cells. Now, we always thought that MS was a T cell disease. There are B cells and T cells. We always focused on T cells, and we got great results, but not good enough. So now we're starting to look at B cells as well. And so now we're knocking out B cells, and ocrelizumab knocks out B cells, and when the cells come back, which may take 6 months or so, it knocks them out for a long time. The cells that come back don't attack the myelin very strongly. It's a milder form. So it resets the immune system. So you got these cells going bam, 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 bam. Then they go away, and people do really well. And then they come back, and 6 to 12 months later, but they don't go back. They go dip, 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 dip. And they may be much more easier to treat the second time around. So, so then there's, yes?
Is Tecfidera being used in PPMS at all?
It will be sometime, but not now. Right now, they were just trying to get it approved for relapsing remitting, but it has the potential to have neuroprotection. It makes sense that it would be used in that. It helps, it's an antioxidant. It helps decrease certain cells that stimulate the destruction, and it has a way to counteract that. So I expect to see it. Anyway, here's a new drug that it decreases the buildup of sodium and potassium inside the cells, because that causes cell damage. This is not about an immune system. This is about what causes cells to not function very well. This has the ability to do that. And that they only treated 14 patients with primary progressive MS, but it was encouraging results. Now they're treating it with optic neuritis as well. So this is a drug that keep an eye on. And then the next one, have you ever heard of coenzyme Q? It's one of the complementary alternative medicine. It's an antioxidant. It's neuroprotective. And it may increase the cell growth of cells that are damaged or gone. So this is another drug to keep an eye on. All right, now we've got some specific treatments. There is a protein called lingo in the body, naturally. And it halts myelin growth and it halts neuronal growth. Usually it's well under control. But in MS, it's too much activity. So this is an antibody made against lingo. It's called an anti-lingo antibody. And we're seeing increase in myelin. Now these studies have been done mainly in animals. But there is a study that was started in the last year on humans as well. So if we can, and it was safe. First they wanted to see if it was safe. It appears to be safe in humans. And so now it's being treated in both secondary progressive and primary progressive patients just to see if it's safe. Next step is going to be see if it's effective. But it makes sense. It's very effective in the animal models. There's a drug called MIS-1416 that actually helps fight infections. It helps fight what we call the innate immune system, and not the B cells and the T cells, but other types of the immune system, which we thought wouldn't help at all. Turns out 8 out of 10 patients with secondary progressive disease improved on this drug. Improved. That's great. And then recently there is you take peptides. Myelin basic protein is a series of peptides. You put them together and you get myelin basic protein. Well, if you take, some of those are very active immunologic stimulators. If you take those out, myelin basic protein is this long, you take out a little segment like this. That seems to be the active part. And you inject that back into the body. You can do something called tolerize the immune system. You can stop the immune system damage. And now there are some studies in clinical trials that shows that works. The study was done in relapse remitting MS, but the relapse rate was reduced by 65%, which is huge. But it has great potential for secondary progressive and primary progressive disease as well, I think. Sure.
The number 4, the anti-lingo.
Yes.
When it said that it halts myelin and neuron growth, don't we want to grow more myelin?
Yes, that's bad. Lingo's bad.
Lingo's bad.
So we put an antibody in that knocks out the lingo.
Okay.
And if you knock out the lingo, the body can grow cells. So, but it's a good question. Thank you for bringing it up. Stem cells. I could talk a long time about stem cells. Stem cells is a hot topic. My personal opinion is, my professional opinion is it's not ready for prime time. So don't be going down to Mexico and getting fetal stem cells injected into your body. I've had patients do that, and some have died. Okay, so it's not a good idea. It's being done scientifically. There's 3 different approaches. One is that you You take the bone marrow cells, which is where our stem cells are, and you wipe them out. You give them drugs, whatever it takes to wipe out the immune system. And then the immune system comes back with the cells that you've wiped out, and you put them back into the patient, and it resets the immune system. It's like ocrelizumab. They're different cells. So you take out the cells, you wipe them out, you put them back into the patients, and they do better. Those cells are not as toxic. And then we actually have cells that are called mesenchymal stem cells, which are like fat and skin cells, regular cells that you can train to turn into brain cells. Pretty fascinating, isn't it? And it's been done. We haven't been able to do it on mass production yet. We still have to study them more, but it's there. And then the latest thing that we're hearing about is actually take bone marrow cells and put them directly back into the body's spinal fluid with a spinal tap. That's early. But nonetheless, stem cells are here. I think they're going to be very valuable. I think we don't know how to use them yet. I mean, one of the problems that I'm concerned about is that let's say you have a stem cell that you can get to continue to reproduce myelin or even brain cells or whatever. How do you stop them? There's got to be a control mechanism here. So I'm not recommending people go out and have stem cells right now, but I can tell you, keep an eye out. And then anything that's an antioxidant that decreases nitric oxide or glutamate, which are things that are really bad. They're radicals that cause havoc. So we'll look at any product that does that. And then also, we want products that increase the growth. And there's a growth factor called brain-derived neurotrophic factor, which is seen with Copaxone and with the interferons. And that may be one of the ways that they work. So now, if that really does one of the reasons that they work, then let's get drugs that are better, more powerful to do that, to actually stimulate brain growth. And the latest one, which was last week, was NDC 1308. Okay, well, what is that? Well, estradiol is sort of like an estrogen compound. And they looked at all the molecular structures of estradiol, and they picked out some that were very stimulating towards cells like myelin in the animal model. And so now they've selected these out, and they're treating the animals are successful, and now they're contemplating treating in humans, stimulating the body to grow new cells. And estriol, which is a product that's like estradiol, is an estrogen. Estriol is the estrogen hormone that goes up during pregnancy. That's being studied right now. Now, it turns out it's different, has different properties, the NDC 1308. But it's still, I think it could be very helpful. The preliminary data with estriol was very helpful. All right, so as far as emerging treatments, I've just listed these. I'm not going to talk about them. Other things, these are the things that we're doing. You can look them up on the internet. The conclusion is that treatments for progressive MS are actively being pursued. You're going to see results in the next 1 to 3 years. This is not the forgotten disease anymore, and I want you to keep the faith. And so with that, I'm going to go to complementary alternative medicine. I'll ask a question while I'm doing this. Any questions? I'll answer questions. Are you excited? I'm excited when I talk about primary progressive MS and secondary progressive, because I think we're at the stage we were 25 years ago when we were talking about relapsing remitting. We think we know what to do. Yes, ma'am.
Okay, do you hear anything about that 40 and Copaxone? 40?
It's closed. Yeah, it's approved. You'll be able to get it. It's 40. It's the normal dose of Copaxone is 20 milligrams a day. There's a new formulation. It's 40 milligrams 3 times a week, and it was just approved. So good news. Okay, these things are so small, it's hard for me to see. Yes?
The stem cell stuff, so you addressed how do we turn it off, but do we know how to turn it on to make the exact type of cell needed, or is it just willy-nilly?
First of all, it's a really good question. And the answer is that we're putting these stem cells back into animals and now back into people, and they know what to do. They know, these are smart. It's That's fascinating.